Welcome, and thank you for joining this webinar in the COVID-19 and Humanitarian Settings Exploring the Controversial Issues series, produced by the READY Initiative, the Johns Hopkins Center for Humanitarian Health, the Health and Humanitarian Crises Center at the London School of Hygiene and Tropical Medicine, and the Geneva Center of Humanitarian Studies. During this webinar, we encourage you to ask questions by using the Q&A feature directly in Zoom. Some of these questions will be addressed in the Q&A section following the panel discussion. Access to today's recording will be available after the webinar at ready-initiative.org and on the websites of the three universities. We also encourage you to visit the COVID-19 Humanitarian platform at covid19humanitarian.com, which curates, analyzes, and interprets guidelines and interventions being implemented in a variety of humanitarian settings to prepare for, respond, and adapt to COVID-19. The platform also has a COVID-19 humanitarian tracker with real-time data for affected countries. It is now my pleasure to introduce our moderator for today, Director of the Geneva Center of Humanitarian Studies, Professor Karl Blanche.
Thank you very much, Ryan. Thank you very much, and welcome everybody to this webinar on the essential health services and prioritization. One of the key question we had received from a lot of humanitarian organizations when we started this initiative on the COVID-19 humanitarian platform was all about which services or interventions should I postpone and pause, and which one should be continued during the pandemic. And recently, UNICEF has conducted a survey in 73 in a few, not 73, in 23 countries affected by humanitarian crises or being fragile states. And they're trying to understand the disruption of health services. They found out that quite a few services had been underutilized by patients because of fear of going to the hospital or the facility or the health center, or by the restriction of movement as well of populations. But the third reason for interruption of services was due to the closure of services, the postponement of the essential services. So one of the key questions for us for humanitarian settings is very much understanding which services should I postpone to guarantee the safety of patients and healthcare workers, on which basis should we make these kind of decisions, and what is the cost of not delivering these services. In a recent paper published in the Lancet Global Health by WHO it's a modeling study on projected costs. They calculated that 20% of the global cost of the pandemic response will be needs to be invested on maintaining essential health services. And to answer all these questions today, we've got a great panel of practitioners, academics, and policymakers. So I would like to start with Apostolos. Apostolos Vaisis is a medical doctor based at the headquarters of Médecins Sans Frontières, Greece, and you're the director of the Medical Operations Support Unit in Athens. But I've been in touch with you for the last few months, and I know you back and forth in different places in Greece, working with refugee populations. I would like to know, I know you come back from Samos and other hotspots in Greece. I would like to know, what have you seen on the ground? Which services have been interrupted, and for which reason?
Yeah. Thank you very much, Carl, for the introduction, and also for the excellent panelists and the webinar. So the situation currently at the moment for the asylum seekers and refugees in Greece is as follows. People, first of all, they get sick physically and mentally on the camp that they are staying. So the picture you see today regarding the situation in the camp is the following. You have an overcrowding that, for example, in Samos is 6 times more people than the capacity of the camp. You have camps that they are with no doctors. So out of the 5 camps in the hotspots on the island, there are no doctors available. You have restriction of movement since March. And then when the outbreak of COVID had been taking place in different camps, those camps have been under the quarantine, and the few resources available have been offered only for the management of COVID, leaving all the rest of the medical services without no assistance. In addition to that, more than 50% of the people who are living on the state-run facilities are lacking a security social number that allows them, when the hospitals are not having services because they're focused on COVID, to have access to healthcare. So 50% of them, by definition, they don't have access to healthcare. On the top of that, because we would like to see the situation of the people based on WHO definition being physical health, mental health, and well-being, those people, they don't have access to basic services. That means shelter. You have tents of less than 3 square meters where 8 people are staying there. It means water. People are not meeting even the minimum standards of sphere standards. Then you have one water point for 1,300 people. You have 1 toilet for 300 people. At the same time, the overcrowding situation and queuing for food, it takes them about 9 hours a day to queue. That also, it is something that's quite difficult. So in a way, those people are living in bad living conditions. The people are living in a violent environment, and the access to health services, it is almost minimum or almost zero.
So how do you explain the interruption of services? Is it due to a decision by the government to restrict movement of healthcare professionals to these hotspots, or are there other explanations?
Well, first of all, I think the migrants and refugees in Greece are just numbers. And I think this is something that those people are not the same like the rest of the other people. So from the beginning, the conditions that people were living and the service offered to them were very minimum. And in addition to that, what was very negative done by the side of the Greek government was implementation of restrictions of the movement for those people, and restriction of movement also for the humanitarian actors and other people to provide services, including mental health services, including other creative services for the population. But just the restriction of the movement, not allowing people even to move out of the camp, taking the fresh air, when he talks about relaxing. So I think it is a situation that is being chosen on political grounds. So that, in addition to the difficulties that the country is facing for the services, especially on locations like on the Greek islands, where already the capacity it is limited for the local population, this has been creating a lot of difficulties for people to access the services.
Thank you very much, Apostolos. Kjell-Ann Johansson, you are a professor in medical ethics at Bergen Center for Ethics and Priority Setting at University of Bergen, and we have worked together. I know your specialty is not humanitarian crisis, but is priority setting of essential services. So in the humanitarian sector, we usually have difficulty to make tough decisions on stopping or postponing key services. And I think people like you can actually guide us or guide the sector on approaches or criteria on how to make these kind of decisions. So can you tell us more about your work and the latest paper we published together on the selection of 120 essential health interventions?
Yeah, thank you, Carl. Yeah, so when you talk about priority setting, the paper you refer to that we worked on together, we tried to provide some concrete guidance with what are the most crucial, most important essential services that should not be deprioritized or removed from the health system because of COVID-19, because they are so important. That was the main idea behind the paper, and it's a really difficult and ambitious task, but I think we need some concrete guidance in both the humanitarian sector and also for governments in low and middle income country on these issues. So then the approach we used for the paper in BMJ Global Health, we started by using evidence from a large work disease control priorities consisting of a huge network of international experts, 300 people that have over many years tried to define what are essential services. And they try to implement a systematic approach in defining what are the most important services using 3 important criteria. And one of them is cost effectiveness, because it's very important that you get a high return from the investments you have, because resources are scarce, both for development aid organizations, but also for governments that maybe spend around $30 per capita on health. So cost effectiveness was one criteria. And we also, the DCP had 2 other criteria. One was also priority to worse off, giving priority to health services that benefits the poorest, those with the most severe condition, those that live in really remote areas. And the third criterion was to give priority to intervention that prevents poverty, that prevents people into getting into medical impoverishment. And based on these very systematic criteria, they ended up with a high priority package consisting of 115 key services. And that's where our work started on the paper, because we wanted to take this general list that was supposed to be guidance for countries. How can this be relevant in a COVID situation we are now? And then we added one important criterion, and that was urgency, because we cannot recommend all services. Resources are scarce. And then we said, let's give priority to interventions where it is very important to don't waste time, because if you waste time, the effectiveness of the intervention will diminish. So then we selected not many actually, it was only 5 interventions we removed. It was like cataract surgery, cleft lip palate surgery. Those were removed and we specified them a little bit. But then in the end, based on this process, working together with also decision makers from Afghanistan, Ethiopia and Zanzibar that have a lot of experience with these kind of priority setting processes, we ended up with a list of 120 interventions in the paper. Yeah.
Thank you very much. Jalan, why in your, I remember, I mean, this paper has protecting essential services, and it's a very strong message sent by the authors, the co-authors. But I know it was a strong message from University of Bergen. Can you explain a little bit what do you mean by protecting?
Yeah, it can mean several things, but protecting is at least don't reduce the coverage from what the baseline is today. Don't disinvest because you give priority to COVID-19 interventions, because these interventions may be more important than COVID-19 interventions. It's important to remember that many low-income countries, they live with these kind of epidemics on a daily basis, not at the same scale as COVID-19, but maybe. So they are facing multiple crises at the same time. And this is one crisis on top of many other crises. So then it's important to, so when we say essential and protect, we mean don't disinvest. But we discussed in the author group, should we be more, have a stronger message and say, should we even recommend increasing coverage? We were less certain about being clear on that issue. And a third issue we discussed was, should we also say these services are so important that we should maybe recommend universal public finance, saying that these should be provided free of charge for patients, not paying out of pocket. Yeah.
Thank you very much, Alain. So I want to talk to Terry Reynolds. Terry is working at WHO and leads the Clinical Services and Systems Unit in the Department of Integrated Health Services. And you have been you have been as well involved in leading these great WHO publication on maintaining essential health services, which is an operational guidance. And I would like to learn from you, what are the key messages from WHO from this guidance?
Sure, thanks very much, Carl, for having me join today. So the Essential Health Services Guidance was an interesting work stream because we actually did it in two phases, one quite early on in the pandemic. And the first goal was to identify the kinds of fairly high-level strategic shifts that, say, subnational planners, to some extent national policymakers, but a lot also subnational planners, the kind of strategic shifts they were having to make in order to ensure that health services continued to be delivered, with an emphasis on the health services that were not directly for COVID, but overall, really, on how you engage things like safe care seeking, safe transport. And you had to take, we address a lot of different issues because there are a lot of different kinds of disruptions. There are strategic suspensions, which early on in the pandemic, the risk benefit analysis seemed quite clear that there were things that you could strategically suspend for a brief period of time. Now, it looked at, governance mechanisms, the idea of embedding an essential health services focal point within your national response team coordination mechanism, whatever that might be. We sort of flagged that you would have to make explicit choices about services such that when the time came that you could no longer maintain all services, either because of bandwidth or funding or safety considerations, as your transmission scenario evolved, that you would need to have a designated set, more limited set of services that you would want to focus on. And we approached a little bit what the criteria might be that you would use to make that decision, what the large scale criteria might be. And then specifically mentioned several aspects of shifts related to human workforce, to sort of health workforce that would need to happen. And so obviously things like IPC get foregrounded. But also questions of space and patient flow, because you end up in this situation, certain things like acuity-based triage or really validated structured tools to triage patients. Normally, you don't necessarily do that at the primary care clinic level. You would normally do that at the first level hospital in the setting of time-sensitive conditions. But in the setting of COVID, you start shifting downstream a few functions that have to do with screening and triage in order to achieve safety in a new context. So all of those general considerations were in the first iteration of this, which was early. And it was fascinating that between March and June, basically, the scenario had changed so much that it required, we did a revision of the guidance in June, and we'll have another revision of the guidance upcoming. But it was really quite remarkable to go back to that over that interval, because it became very, very clear that some of the things that made sense, that we were all working, even without being explicit, we were, no matter what we knew and what we tried to be aware of, we were all working in a not really accurate way with this horizon of a few months. And you can see it reflected in so many different documents that came out in those first few months. So in June, it was a very interesting shift, the grammar, the verb tenses, the horizon, and a few things just to flag now, and then I'll put in the chat the links to the guidance. But it required a shift to, we took an entirely different approach, that it was clear by that point that we were not talking about something with a beginning, a middle, and end, and then an early recovery phase. It was very clear that we were talking about something with waxing and waning transmission scenarios, where you would need to identify criteria and clear triggers for stopping, starting, and restarting services. It also became clear that we have some work on assessment and sort of tracking over time of what kinds of disruptions there have been in services. It became clear about the second phase that we really needed to distinguish between strategic suspensions and unintentional disruptions. It also became clear that we needed more room to focus on that this was not going to be a short, sharp emergency, that this was going to be a long curve, and that we needed to start looking at any strategic shifts that we made, how do we make them in such a way that the gains and the benefits made in the pandemic context could be incorporated into health system strengthening post. It became clear that we're now in something that you can't really call early recovery, but we have to start calling late pandemic. And one good example of that is that whereas in some places it made sense to suspend, for example, this is just an example, but elective surgeries, what that has now done is created a very serious public health crisis of surgical backlog, even in wealthy countries who have never faced that before, even though that has been a long-standing global health problem in limited resource settings. So all of those things got added into the first part of the document. The second thing we did is created an entire second part that has to do with specific programs, so disease and population specific programs, so NCDs, HIV, child health, et cetera, and created tables that say, okay, for each of your key activities, say vaccination, et cetera, here's the strategic shifts you would need to make. So the new document contains both the overall principles updated for the current context, plus disease and population specific program guidance on how to shift certain activities for safety. Over to you.
Thank you very much, Terry. Thank you very much. I come back to you after talking to Esperanza. Esperanza Martinez is the head of the health department at the International Committee of the Red Cross. And you, of course, you're a medical doctor. We have talked a lot with you and a few colleagues about the position of RCRC in terms of priority setting during the pandemic. Can you tell us more about what kind of decisions, clear strategic decisions, as explained by Terry, have been made by RCRC in this new context?
Thank you very much, Carl, for the invitation. And I really would like to build from what Jelen has said in relation to how to establish priorities. We work basically in contexts affected by armed conflict and violence, and therefore the baselines that in terms of health indicators are already very low. Some of them are in a very fragile state. So any shock is going to render communities with a very quite high level of fragility in terms of health. So for us, very early on, one of the critical decisions taken as an organization was to really maintain the essential services we already provide and we already support. Many of them are supporting ministries of health and health authorities at local level. So really continue to do the investment necessary to maintain as much as possible primary and secondary care engagement. So those level of essential services to make sure that they were not going to be disinvested upon. Facing all the challenges that all the humanitarian organizations face in terms of supply chain, movement of people, and so on. So I think that that was a very clear decision. And also in addition to that, of course, a very specific COVID-19 related activities that are at that time, we just very often say they were so unsexy, that at the time when everyone was talking about ICUs and ventilators and tertiary level of care. And we kept insisting that we need to focus on the essentials. We need to focus on the basics, IPC, primary healthcare level, secondary level of care. And as Terry was saying, pathways, patient pathways in health facilities to prevent dissemination of the disease. But I think I want to build on a point that Terry mentioned of these intentional and unintentional choices. So I think we have to distinguish them, because you have the intentional ones taken by ministries of health, for example, on elective surgery and procedures, that they also had an impact on humanitarian action. For example, our reconstructive surgery engagement for victims of war with long-term sequelas stopped during this period because elective surgery was not taking place. But there are also these unintentional choices taken as well by people and communities. In primary healthcare centers that were still operational during the pandemic, we saw a significant drop on maternal and child health consultations because of curfews, because of restrictions of movement, and also because of fear. So we do have a backlog on essential services, even if essential services were maintained. And so there are these backlogs and consequences that are due to intentional and unintentional choices happening in humanitarian settings. Over to you.
Thank you, Esperanza. At the very early stage of the pandemic, RCRC had been very vocal about detention centers. So when we talk about prioritization, it is also it's not only about services, it is also about specific groups. And I will go back to Apostolos to talk about refugee populations. But what about detention centers, and what kind of situation do we have?
One of the things is healthcare in detention is not only one of those areas of expertise very much linked to the mandate of the organization, but also is the fact that in many countries, the health delivered to detainees sits with the Ministry of Health, in others with the Ministry of Interior, in others with the Ministry of Justice. And there, when you have a pandemic or an emergency situation, it's not very clear who is responsible for providing healthcare. So the detainees or people deprived of freedom somehow fall through the cracks very often. So we know that, and based on experience from Ebola and from previous outbreaks, we basically work very closely, starting with Asia and moving then to the other regions of the world, on strengthening the basics, again, in terms of healthcare delivery, essential services within the prison system, working with all the relevant authorities, and working on the delivery side, but also on the systemic piece side of things. So I think that's a population that very often it's forgotten, because it doesn't sit squarely within Ministry of Health's mandate. And the other thing I want to say, Carl, is that it is very important to see health not only from a health perspective. If we look at COVID, a lot of the interventions were related to water and sanitation. And that's when we want to ensure essential services in health. We also need to make sure that the other elements, as Apostolos was mentioning, sanitation and water, are there. Otherwise, it's going to be very difficult to tackle them. And when we move forward, we need to look at the economic security piece. Many people will not be able to access health because of the significant economic impact. So we really need to look at this from a social determinants perspective moving forward.
Thank you.
Back to you.
Thank you, Esperanza. I want to ask you a few questions before opening the floor to questions coming from the audience. Apostolos, I think it's a question I have for Apostolos and Esperanza. It is about, because you have teams on the ground, do you have a sense, Apostolos, of these excess mortality and morbidity due to the interruption of services in refugee camp or in hotspot? What kind of data do you have or evidence?
Yeah, well, there are not many data that would prove issues of mortality. So far, the only confirmed case among the refugee population is only one case. Now, when it comes to morbidity issues, there are a lot of issues that have been remaining without assistance related to mental health. And definitely on the mental health part, especially the management of cases of both depression, post-traumatic stress disorders, etc., it's something that you cannot measure it very, very well, and the systems are not prepared for that. But we already have been seeing that situation of people having severe medical conditions have been worse or have been more difficult, and we have people also who have been having a situation, new situations. So more and more people we see today that there are a new list of patients who are asking for mental health support. And I'm talking about today because yesterday Greece started again the lockdown, full lockdown for the whole population. So the situation went back again into what was before. But what we found out when on a little opening of the society, we found out that more new patients were coming for mental health assistance. And when it comes regarding the physical health, already the physical health have been under a lot of pressure related to the living conditions. So for me, the situation of the on the refugee camps in Greece is a situation that most of the medical conditions are being created. And I think letting also people with chronic medical conditions with no treatment, we've been seeing those people facing now more difficult to manage, be it blood pressure, be it diabetes, etc. So it's something that there are not really that of comparison, something that we're working on it. But definitely what we've been seeing very clearly and visible is the issue of the mental health part.
Thank you, Apostolos. Esperanza, what kind of situation do you see?
I second what Apostolos have said. The amount of needs in terms of the mental health and psychosocial support in that sphere, it was unaddressed before, and is going to continue to be larger as we move forward. One additional point I want to make is in relation to vaccination. So I already mentioned that we have seen a drop in general consultations in maternal and child health at primary healthcare level. But vaccination, we don't have specific figures yet, but we're working with the Federation, with the International Federation of the Red Cross and the Red Crescent, really on the advocacy piece, as we are all talking about the vaccination for COVID-19 and what do we do with that and what does it take and so on. We also need to remember that we are way behind now in all the vaccination for routine vaccines that we have. We were already not on target, some of them very close to target, and we have gone way back. How big of an impact is still, we need to see statistics yet, but it is obvious in the countries where we work that those efforts have been hampered for different reasons. I mean, it was traveling, quarantine, restrictions of movement, all of the different elements that were associated with the pandemic have had an effect. And one of the problems with that is that it basically is going to harm health indicators moving forward, not only of children, but also in relation to disability, for example. If we get a number of preventable diseases that take hold of communities. So and coming back to the point that Postulus made on chronic diseases, and the suspension of treatment, for example, for diabetic patients is going to have an impact in terms of disability later on. So I think there are a lot of indicators that we will need to monitor moving forward in short term, but also very long term in terms of disability.
Esperanza, ICRC is working a lot with the National Red Cross societies. And so, and one of the key questions I have is about how do we prioritize and at which level of the health system? And what is the role of community health workers in some of the countries where you work? Have they stopped working? Are they completely mobilized on the pandemic, in the surveillance system? What kind of role do they have?
An essential role. They have the network of national Red Crescent and Red Cross societies around the world has 92 national societies. And they all work with volunteers and community at the community level. And these volunteers, but also community health workers have been essential during the pandemic. Not only helping to dispel myths in relation to COVID-19, so information as aid has been one of the critical elements that we have been working together. And this is a joint effort not only of the ICRC or the IFRC, but also together with WHO and many other humanitarian agencies coming together to make sure that the right level of information is disseminated to communities. Also the element of access to communities themselves, to be able to really monitor what's happening with the communities. They are instrumental. And we need to consider that in many countries, the national societies play a very key role in supporting ministries of health. In others, they don't. They are not very closely linked. But then one of the big efforts that the movement, the Red Cross and Red Crescent movement is at the moment undertaking is really recognizing the role that volunteers and community health workers play into this. And I just want to say one last point that is super essential in this discussion of essential health services is really the community actors. So the entry points, community leaders, but not only the male leader, but also female community leaders are extremely important to access maternal and child health pockets of communities that are not accessing those services. And we have great experience during COVID-19 reaching out as well through scholars and, for example, in the Muslim world to make sure that messaging in relation to COVID could be translated in a way that spoke, that was aligned with Islamic teaching and therefore acceptable by communities. So we do need really to tackle into all of this network of actors on the ground, particularly when you have violence around conflict, to make sure that the messages that are coming in relation to healthcare services are consistent with what the communities accept and what the communities believe.
Excellent. And I think we've got in the audience a few questions about trust, but I will go back to this very important issue. Then I've got a question for Chelan and Terry. In the humanitarian sector, we have a lot of guidance, we have a lot of guidelines, a few standards, and so on. So priority setting, in a sense, is not very new. It's something we've been doing. We are now in a new context, in a very new environment. And I wonder, Chelan, even if you do not work in this kind of context, what kind of tools, approaches actually could be that you have been developing with a few ministries and partners could be actually deployed or used in this kind of context?
Yeah, that's a good question. Currently, we are working with the Ministry of Health in Zanzibar, and we have been working with the Ministry of Health in Ethiopia about developing essential healthcare packages in general. And what are the tools? I would say it's a complex process, and the challenge is people very often have strong intuitions about what is right to do, and it very quickly becomes emotional. Just remember the debate some years back in the US where Sarah Palin accused the Democrats for organizing death panels when they tried to make priority setting an explicit exercise. And that totally shut down the whole open democratic debate about what should be high priority, what should be low priority. And then instead, you push this very important discussion implicit into the system and leave it to people's intuition. So I would say the most important tool is to be explicit about these are hard choices. No one has the right answer to what are the optimal priorities, but let's at least try to have a democratic open discussion about what should be selection criteria, how do they fit very strong ethical theories, how do they fit people's intuition, try to identify disagreements, but then at the same time try to be concrete and link it with concrete services, what should be in, what should be out, what kind of delivery platforms, what quality of care should you have. I think that is important, and also so strengthening the political system at the same time as you also strengthen the technical capacity in the system to manage to do very advanced health economic evaluations, monitor equity impact, and so on. So yeah, that's my brief answer to it.
Thank you very much. Yeah, we've seen that in Afghanistan with Terry when we were developing this new package of health services, where actually it's a negotiation that is not a core negotiation. It's a negotiation happening in a social and political environment. So in a way, Terry, we can use a lot of tools to guide this process, but there's no magic bullet or magic software that can do the job for us. Terry, can you talk us about the UHC Compendium and what you've been trying to develop?
Sure, Carl, thanks. Yeah, I think, so there's a couple of things I'll mention that are more general and not specific to humanitarian context, but even those have been, as it happens, highly informed by experience in what we think of as more traditional humanitarian context. So first, I think it's important that we recognize that there's three different things. There's process, there's tools, and then there's sort of criteria. Right. And so WHO has pretty clear guidance on overall the process of approaching a national package. And then we are increasingly developing a couple tools that I want to talk to you about because they were very much built on our experiences working with Somalia and Afghanistan. And then there are criteria by which you choose. And to some extent, those will always be more local than the other two, right? You can imagine global guidance on the first two, and then you can talk about equity principles and you can talk about, global cost effectiveness indices and things like that. But ultimately criteria, whether or not you prioritize cost, say almost everybody will prioritize effectiveness, right? And then almost everybody will prioritize cost. And then there's equity, and then there's context, and then there's political agendas. And one of the things I think there's two things that are very interesting to think about. One is that a lot of the capacity that has been built up over the last decade or two under the umbrella of universal health coverage, so the capacity to define a subset of all possible services, to be explicit about how you chose that subset, and then to say, why am I choosing this subset? Usually it is, this is what I want to be a focus of public funds, right? But those three capacities to do those things are precisely analogous to the capacities that are needed to choose an even smaller subset of services that you want to focus your resources of various kinds in the setting of COVID or another kind of emergency, right? What I think is very interesting, though, is really commonly the criteria that climb to the top of your list and the sequence of criteria that the way you sequence criteria for most settings will change dramatically, either in a kind of chronic waxing and waning humanitarian context or in a in a specific event like this pandemic. So, for example, you really, as Esperanza mentioned, and as Jalarn mentioned, it's, you know, the idea of time-sensitive services where you really need to respond immediately to things that will kill you within on the order of hours to days. That particular principle shuffles quite high, because if you don't protect those people right now, you won't get another chance to do it. So if you are dealing with a crisis that is going to last 3 months, you still want to maintain all your emergency care services. And it is completely acceptable to suspend certain services that don't cause trouble when they're suspended for 3 months or 6 months or even 1 year. When you're looking at it from the point of view of a national health service package, you don't want to suspend those services, because in many cases, those are the ones like, you know, regular monitoring of blood pressure that are going to get you the huge bang for your buck 20 years down the road. So one, it's really interesting to think about, be very aware that I think countries will use very much shuffle the priority of their different criteria as they choose. Then the other thing is, so WHO has created this huge project called the Uhc Compendium, which on the one hand is a database of a lot of different interventions from which countries might choose. One of the important pieces of innovation in it is when you look at list of services that countries are using for a lot of different reasons, but when we call them packages, we call them benefit packages, service packages. When you look at these list of services, they're a little bit crazy sometimes in the sense that they, in terms of granularity, they go from things like vitamin A and a specific dose, and then one line that says like surgery and trauma care. So, you know, they're very much all over the place, and it's largely because they follow a series of completely independent, unlinked cost effectiveness studies that are out in the world. So you get this very strange thing, and the problem with it is that it does not support integrated service delivery. So what we lack right now in the world is a common language, an architecture to look systematically through health areas and to think about how they relate to each other and to formulate them in a way that would support integrated service delivery. So most countries and most groups are doing, on the one hand, service selection, and on the other, a completely incompatible set of guidance about integrated service delivery. So the compendium aims at having this systematic architecture refined into a common set of formulations, granularity. It's a common language that can be used by any country anywhere. You might choose to use it. It's only a tool. It's not going to tell you what your criteria are. You might choose to use it to develop a national service package, but you also might choose to use it to develop a set of humanitarian service, you know, priorities for a humanitarian context. And the value, I think, of having this product out there is that then humanitarian actors who may or may not be centrally contracted under a government strategy umbrella, then the work that they do, maybe independently from each other, will then align and be, once things, you know, ideally convergence is what we're after, right? So strengthening the national health system and the national governance. And when these things come together, they will be expressed in a common language. So that is one of the points of the Uhc Compendium. Linked to that is a service selection interface that you've seen in a couple of the cluster meetings that allows countries to systematically choose services, slide them to a level of a health system, a platform of delivery, and then to move that platform as the situation dynamically evolves. So it's a product that was developed and conceptualized under the umbrella of UHC. But I think as it happens, it can be quite effective to support a different process of prioritization. But I do think it's important to recognize that the criteria will likely shift for most countries in most places.
Yeah, and I think I mean, the work Chelan and his team and WHO has been doing in a few other countries could be highly important and useful for the humanitarian sector. I do think that we have to do this work prioritization, using this kind of evidence and the work you've been doing in trying to standardizing or harmonizing what we talk about and how we define interventions. Now, Apostolos, you wanted to make an intervention?
Just only one minute. I wanted just to tell you that what we achieved and we made possible during the COVID ongoing outbreak in Greece, we did not stop our activities. So we adapt our activities and we continued all the service provided. We aim to the government and ask them to manage differently the situation in the camps by working with the community, improving the water and sanitation. And we tried from the beginning to ensure there is a system of diagnosis and testing. And because this was not listened by the side of the government, and because they blocked us, even they closed our isolation center, we faced the fire in Moria. We had you had 12,000 people in the street with the camp being burned out. And we faced a situation in Samos where, due to the COVID outbreak, everybody was locked inside of the camp and all the services stopped. So I think there are examples around the world, but also examples in developed world that can be taken into consideration. So with some more efforts, and we don't need to stop those activities.
Absolutely. Esperanza, we have a question from the audience about, and you touched upon that earlier, is about the trust of patients and communities vis-a-vis health services when we interrupt services, and combined with the fear of infection and this kind of stressful environment, how can we communicate with communities and populations about this type of decisions we make about essential services?
Yeah, I think it's at the core of community engagement. Basically, one of the things that we discovered over and over again is you cannot just basically deploy an effective health response in the middle of a crisis if you haven't built already a network that allows you to communicate and involve communities. And it doesn't matter if we are talking about a refugee camp or we are talking about a very, very highly crowded, low resource area in a city, or we are talking about an armed conflict situation. Trust is quite significant and important. Now, it is built upon time, and I think from an ICRC perspective, and as we work in areas affected by conflict, it really relies a lot on having health seen as an impartial and neutral activity. So it's an activity that is not driven by other drivers rather than needs of population. That is not tainted by political aims, that is not tainted by armed faction aims or religion and so on. Because the moment we move from that neutral, impartial and humanitarian space, then you start to break down the trust of the communities. And this is quite important. One thing that I wanted to, Carl, if you don't mind to add on this, is that we have here been talking about the protection of healthcare services. For the ICRC, the protection really has a different and expanded meaning in the sense that access to healthcare services and essential services in armed conflict is also protected by international humanitarian law and the rules of war. So when we talk about protecting healthcare and essential services, we are talking about making sure that health facilities are not attacked, making sure that healthcare workers are protected, not only from armed actors, but also from the community. And we have seen a lot of stigmatization and attacks during COVID. So those elements as well are important, because very often the lack of services is not due to an institutional issue, but the fact that healthcare workers are unable to work or are driven away by attacks. So this is an expanded notion of protection that is quite important also to drive on.
Thank you very much. Chenan, and I think there's a question about seasonal changes. And you're very well placed in working in Ethiopia and Zanzibar. How do we take into account the seasons in the basic package of services? How do you do?
Yeah, that's a good question. I'm not sure if we managed that in a good way, to be honest. But we tried to address it because we tried to be very generic in the COVID-19 essential service paper, where we specify that you may address interventions depending on the malaria season and depending also on the size of the malaria epidemic. So, but we are kind of vague and more work would be needed here. And I think it's probably better to work with local governments to carve out this seasonality of many of the infectious disease problems. Yeah.
Thank you.
That's the honest answer.
Thank you. Thank you. Yes, and we have, I mean, there have been quite a few list of essential interventions developed either by WHO or DCP3. And one of the key recommendations when you implement this kind of list is very much to then go back to the context and look at seasons, looking at epidemiological profile of the population by province, by regions, making sure that you adapt the package to different areas of the country.
Yeah, can I just, because it's kind of interesting the work we now are involved in Zanzibar, because then very often all the epidemiological data you have about Zanzibar comes from Tanzania mainland. So then we have to rely on a lot of epi data from Tanzania mainland, and the situation so Zanzibar is like a subnational region in Tanzania, and then it's a challenge so we develop kind of a subnational package for Zanzibar, where, for example, malaria interventions are not as relevant in the Zanzibar context, because they have performed well over so many years, and they have almost they have reduced the prevalence and incidence rate of malaria substantially. So then the malaria interventions in Zanzibar are totally different from what it is in Tanzania mainland. So just an example of why you cannot just bluntly implement the list of services. You need to also adapt them. Thank you.
Jen-Ann and Terry, the question, you mentioned that, but just want to make sure that we highlight that. A question from the audience about criteria to sustain or postpone interventions. Can you simply highlight the key criteria you have selected, Jen-Ann and then Terry?
Yeah, the postponement decision, we discussed it in the group working on the paper, and then it's the time-sensitive criterion, urgency, meaning that if you don't provide this service today, people will die today. If you postpone it today 6 months, not much will happen. You can do the cataract surgery in 6 months and you will have the same benefit, but you cannot stop antibiotics for sepsis, because that is very time sensitive. So urgency was the criterion we felt captured this postponement problem.
Terry?
Yeah, Carl, thanks. I think there's a couple of different approaches to this. So we did not do, we were not doing the same kind of exercise, right? We were trying to give global guidance for all countries. So what we did is, and it wasn't a small group of people where we had the option of choosing the criteria, but so yes, absolutely. The thing we're 100% in agreement on is the time sensitive nature. So that is one of the clear areas flagged in the EHS guidance. However, there are also others that you wouldn't actually count. Not only are they not exactly time sensitive, but they are not even arguably treatments. And those are things like vaccinations. And there is another really important criteria that has to do with, you can do this thing, which is neither an emergency nor a treatment right now, to avoid a lot of emergencies in treatment. And so we were quite explicit about how you would decide what goes into this category. And one of those is to do a specific risk benefit analysis, and those are quite different. The other criteria that is really important is when you're looking at a set of services that are aimed at a condition that has syndromic overlap with COVID itself, you also need to do something different. So an example of that is, it is one thing to tell people to stay at home with fever in Switzerland. It is a totally different thing to tell people to stay at home with fever in a malaria endemic area, depending on prevalence. So I think that on the one hand, I absolutely agree. One clear, very straightforward priority is the things that are going to kill you today or tomorrow, on the order of hours to days. That one's easy, to be honest. Then there are these others that really, when you start analyzing it, cannot even be suspended for much beyond a couple of weeks without causing consequences. The other one of those that's very interesting that won't flag if you just look at sort of things that are going to kill you have to do with sexual and reproductive health services. So, for a whole lot of reasons, a lot of babies result from lockdowns, and so there's a number of things like that will cause serious public health consequences in the near term. That won't kill people in the near term. So I think there are a few more criteria, and it's kind of it's the same consideration in general, which is what is going to cause an irreversible public health consequence in the near term. And there are things that are not going to manifest on the individual person for a while, but the consequences already happened and is irreversible, and that is things like losing your vaccination control and your herd immunity, getting pregnant, and then specifically other febrile illnesses. Those are all key other things. And those are flagged kind of in the guidance over. And then let's be very, very clear, we're no longer in the short term about this, right? We've long since passed the threshold where you can, at the beginning, we were all like, sure, suspend your routine dental care visit. We're now getting to the point where we're seeing all of the loss of that. So, okay.
Thank you very much, Terry. Esperanza, you wanted to
just a quick point building on what Terry has said, and just an example. We, for example, stopped very early in the pandemic all the physical rehabilitation services that we provide to people amputated by war. But there was one service we did not stop, which is the management of babies with club foot, because it produces lifelong consequences. So it's not a life-saving, but it's extremely painful, and it creates discapacity if we don't treat it. So it really very contextualized, but I think those choices can be made when you have very clear guidelines of what an understanding of the consequences. So, and to build on that, there is a lot of work I think that agencies have done in relation to prioritization, how many resources you have, and you need to allocate and so on. What probably we're missing is a more, as you have done with this 120, is really a more aggregated kind of frame in which basically contextualization then can be done. But it's doable. I mean, we stop elective surgery or reconstructive surgery, but we did not stop weapon-wounded surgery, fresh cases, and people that will need surgery today. Similar choices and ministries of health all over the place have occurred. So it's doable. It just requires that element of bringing your framework, technical framework, into the actual context to take those decisions.
Thank you, Esperanza. Jean-Anne, you wanted to add something?
Yeah, I just wanted to elaborate a bit on the urgency criterion, because normally I see urgency, it relates to cost effectiveness, because it's a bit difficult to use it as a separate criterion when you work with priority setting. But in this particular situation, we consider urgency maybe to play an additional role. But I agree with Terry when she says that maybe now we're at the point where we maybe need to look beyond urgency and apply the standard criteria for priority setting, cost effectiveness, priority to worse off, financial risk protection, and so on, because it's a bit hard to apply the urgency criteria into priority setting, for example, because late stage cancers, it's a fatal disease. If you don't do anything today, you may die, but still maybe you shouldn't do it because there is a cost of doing it. Then you may save less lives by giving antihypertensives. But the lives you save will be in the future. And that is why applying urgency is problematic in itself. Yeah, just wanted to mention.
A final word with Apostolos, because we're just at the end of a webinar. The situation of refugee population in Greece, as Chalan just mentioned as well, about long-term situations. So basically, there is no emergency to resolve here. It's very much about the long-term health status of populations. So how do you see now in the very near future, all these essential services going back, being delivered again at the right place to the right people?
Well, I think it would be, again, another difficulty, as I mentioned from the beginning, because those people are not being considered to be part of the society. If they would be considered to be part of the society, definitely they would be probably having at least a minimum access like the rest of the population will have. Even though through our work in those camps, we've been showing also with specific examples, working with the population, we're able to vaccinate the children, we're able to provide sexual reproductive health, were able to do testing and diagnosis. So I think in a way, even those as examples could be copy-paste by different camps around the country, but also from the public healthcare system. So the question here at the moment is the political will of the governments and the political will to take care of those people. I think, for example, just the last point to mention is that in situation of emergency where you are not offering any service and suddenly when an outbreak comes, you bring in millions of euros to respond, does not make any sense. You could spend less from the beginning and take care of the situation and not just come in the middle of an emergency in order to respond just for communication purposes.
Thank you. Thank you, Apostolos. Thank you, Apostolos, Jalan, Terry, and Esperanza for this great webinar. We have to close here. We're going to meet on December the 9th for another monthly webinar on the shielding approach in humanitarian settings. Was it or will it ever be fit for purpose? Thank you very much all, and have a great week. Thank you very much.
Thank you.